Hello, everyone. So we're going to go over terms and concepts for the chapter on mental health, which is chapter 13. And I am a clinical psychologist by training, so I know quite a bit about this. I haven't practiced since I was in graduate school, but I do go to conferences that focus on clinical work so that I can stay up to date on what's going on in the field. So hopefully my insights here might be helpful to you. So your book talks a little bit about historical perspectives here, and hysteria is really, they talk about it being the first mental illness associated with women, but it's really the first mental illness that we have documented in history. Certainly there were probably things in prehistory, pre-written record that were done, but it was first seen in a text written in ancient Egypt. So this has been around for a while. It's associated with reproduction, sexuality, or traditional femininity at different points in history. So the Egyptians believed hysteria originated from the uterus wandering around the body. Literally, they thought the uterus got up and walked around your body, and if you were having a numb arm, that means your uterus was wedged in your shoulder. And they included things like seizures, fears, and a sense of suffocation. So probably what we would indicate as anxiety and panic attacks today. I'm not really sure how the seizures got lumped in there, but there you go. The ancient Greeks said hysteria was caused by a sad uterus, quote unquote, that wanted to be linked to a man, of course. It included, again, tremors and anxiety, so we see some similar symptoms. Remember, the ancient Greeks and the ancient Egyptians did communicate with each other. And then treatments were drinking wine, vigorous sex with men, and orgies. And then from the Middle Ages to the 17th century, they thought it signaled demonic possession. And any woman who was nonconforming was labeled as a witch. And unfortunately, many of these women were killed, right? They burned at the stake. Or here in Virginia Beach, we actually have a road called Witch Duck Road. And that was named after the Witch of Pungo, who was ducked. And this was a way to test if a woman was a witch. So you tied her up, threw her in a river or other body of water, and if she sank, she was innocent. If she floated, she was a witch. So think about that one. You're killing innocent women, potentially, right? She was eventually pardoned, but not until a couple centuries after she died. But she did live. And if you're in this area and you see Centerra Bayside on Independence Boulevard, there's actually a statue of her in front of there with some animals. So interesting. Persecution of witches led to deaths of tens of thousands of women, and really this was just a way to keep outspoken women quiet. One thing I should say too is that we had this idea of hysteria really into the 18 and 1900s, and one of the ways they tried to treat it then was through manual stimulation, so basically bringing the woman to orgasm. And this is actually how the vibrator was invented. It was invented as part of a medical procedure because some doctors actually were getting tendinitis from doing this. So fun fact, there's a movie about this called Hysteria, which is sort of weird because they make it into a romantic comedy, but still an interesting watch. So there you go. All right, so in terms of how we've regulated madness, so there are things like drapetomania, which was a mental disorder that described an enslaved person who had a strong desire to escape slavery. So again, you see how we use mental health to try to control people. Clearly, if someone wanted their freedom, they were crazy. Again, horrifying to us today, but people believe these types of things. It used to be if you had a mental health disorder, you were sent to an institution, a hospital, for life. And sometimes these were horrible, horrible places. If you want to read horrible stories about this, read about Bedlam in London. They just horrible treatment of people. But sometimes this was the best place for people who couldn't function independently. However, in the latter half of the 20th century, so really around the 1970s-ish, they just started shutting these down. Like they lost funding, and so they just released people. So that led to an increase in use of psychiatric medications on an outpatient basis, a lot of concern for patients' rights, and there's a lot of decreased funding. So even let's say you're suicidal and you go to the hospital, typically they're only going to do like a 48 or 72-hour hold, and then typically your insurance might not pay beyond that, so then you're released. It's not the case with everyone who goes and who needs this type of care, but unfortunately we know that homelessness is in part linked to deinstitutionalization, because there are some people with mental health issues who cannot function independently and thus have ended up in dire financial straits and in lack of housing. There's also sort of the popularization of the medical model, which assumes that mental health concerns are the result of physical problems and can be treated through medical intervention. And this is reflected in the development and heavy reliance on what's called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. Little quick background on the DSM. So this is created, published by people get money from, the American Psychiatric Association. So this is run by psychiatrists who, quick refresher or new information for those of you who might not know, psychiatrists go to med school, so they're MDs, and then they do a residency that focuses on psychiatry. Some psychiatrists are trained in therapy, but most are not in this day and age. So they're prescribing, essentially. The DSM has very little influence from psychologists who do a vast majority of the research on this, and so this is very controversial within the psychology field. Here's some feminist concerns about the DSM. So it's written mostly by a panel of wealthy white American men with ties to the pharmaceutical industry. So if there's a medication for it, traditionally it ends up in the DSM. And some things that like don't seem like mental disorders, like in the DSM-5, which is the most recent one that came out in 2013, restless leg syndrome's in there. Not really a mental disorder in my mind, but it's in there because we have a medication for it. It also tends to sort of like go by trends. So like hoarding's in there now. And while that's like a legit thing that really concerns people, I'm pretty sure it's only in there because there's a TV show about it. So just sort of like make that known. They may view traits, the people who write this, that have been traditionally associated with femininity as abnormal. So this gives the example of dependent personality disorder, which you have like fear of disagreeing with others and difficulty in making everyday decisions without reassurance. It also includes gender dysphoria. This used to be called gender identity disorder. So they argued this is better. But it's basically when an individual expresses a strong desire to be treated as a gender different from the one they were assigned at birth, and they are troubled by it in some way. So that's the dysphoria. And traditionally, the dysphoria is really because they can't live as the gender they want to be assigned. So a lot of feminist psychologists, myself included, really have a problem with diagnosis because it does pathologize people who are trans or non-binary. However, a lot of trans advocates will argue that this is good to have in there because you need a diagnosis the way that the American health system is set up. And so that gives you access to psychotherapy and also can give you access to other gender affirming treatments, such as hormone replacement therapy or even surgical procedures. So right now I think it's important to have, but gosh, do I wish that we don't have to pathologize these people. I mean, just to give you some historical context, up until the 70s, homosexuality was considered a disorder, and we're all pretty ashamed of that right now. So I think in another, 40 years, we're going to be pretty ashamed that gender dysphoria was a disorder. All right, so major depression is the most commonly diagnosed mental health disorder. I believe it's something on the order of about 25% of women are diagnosed with this at some point in their lives. So there are feelings of sadness or emptiness, diminished pleasure in activities, what's called anhedonia, negative thought patterns reflecting worthlessness or guilt, and physical symptoms such as fatigue, weight gain or loss, and excessive sleeping or insomnia. So very troubling. These have to last at least 2 weeks. But typically when people come for treatment for major depression, they last much longer. Now, women are diagnosed disproportionately with major depressive disorder. So I believe, like I said, that women, about 25% of women are diagnosed, and men it's like 12%. And so there's a lot of different potential explanations as to why that is. People try to pin it on hormones, like this is just hormonal, but the links are pretty elusive, with the exception of the literature on postpartum depression, which makes sense because you do have a very radical change there. However, it's also obviously a time where you've got increasing social stressors, right? Lack of sleep, taking care of a small being, right? One of the best descriptions I've heard for what going home from the hospital with a new baby is like, they send you home 2 days after a car crash with another being that you just met that also suffered a car crash, right? So it's understandable why that might be socially related as well. Rumination is one of the things that has a lot of research, gosh, in the past 20 years, I would say. When I go to these clinical conferences, a lot of the time is spent focusing on rumination. So this is the tendency to obsessively mull over one's problems and all the consequences and causes of the situation. And women have a higher tendency to do this than men. So that might partially explain the gender differences. Another theory is self-silencing. So the original article about this was written by Jack and Dill. And the idea here is that women inhibit their self-expression in order to please other people. Traditionally, we think of this as their male partners, but it could be other important relationships in their lives. So they sacrifice their own needs in order to maintain their relationships. So some people argue that they are just doing femininity too well. There are also racial pressures. So Marianismo is a concept that underlies the gender socialization of Latinx girls and women. And it's very similar to self-silencing. It encourages self-sacrifice and repression of anger. And then there's this idea of the strong Black woman, and that women must conform to this who are members of the Black community. I actually had a friend in grad school who did research on this, and this is highly related to things like depression, disordered eating, even experiences of trauma. Another thing people have argued is that we know that discrimination is related to being stressed out, and we know that being stressed out is linked to depression. So women have a lot of stressors that can contribute to depression. You might grow up in a sexist family, you might experience sexual harassment, as we've spoken about the past couple of modules, and then you get to some of the intersectional issues, right? You have racism, heterosexism. Sometimes this in of itself can be more than just stressful, can be traumatic. So for example, a lot of people now are talking about sort of the long-term trauma of slavery and Jim Crow that people who are Black are still experiencing, particularly in America. And then for people who are members of the LGBTQ community, there's conversion therapy. And this seeks to change a client's sexual orientation to heterosexual. And this is shown to have harmful effects. People come out of this have PTSD. The American Psychological Association opposes this. And in fact, it just was made illegal in Virginia to do this on children as of 2020. So it should have been made illegal much sooner, but this is what happens when you get a party in power who actually like looks into the science of these things and cares about the well-being of these kiddos, right? We also know that other things that are related to stress are more often experienced by women. So women are 38% more likely to be living in poverty than men, particularly women of color, women with disabilities, both physical and mental, and single moms are at greater risk of poverty. And this has a negative effect on women's mental health, and it also can be on their physical health. And violence experienced in childhood and or adulthood can contribute to depression as well. Now, anxiety is probably the second most diagnosed category of disorders after depression. Women have higher rates of almost all anxiety disorders than men. This is highlighting just a few of them. So agoraphobia is where you are anxious being outside the home or being in a public place. Agoraphobia translates to fear of the marketplace. So we're thinking big, busy places. Some people with this disorder can make themselves go out, but they're distressed. Some people who have very severe forms of this disorder will essentially be homebound. Generalized anxiety disorder is chronic debilitating worry about pretty much all aspects of your life. So when I was a clinician, if anyone came to me and said, oh, I've always been a worrier since I was a kid, I knew to screen them for this disorder because that's a pretty good indication. This can lead to things like sleep problems concentrating, even physical issues because you're so tense all the time. So very problematic as well. Panic disorder involves panic attacks. So panic attacks come out of the blue, peak really quickly, and they tend to be unpredictable until you get into therapy and sort of recognize what triggers them for you. They're essentially an overreaction of our fight or flight reflex when we don't need it to kick in. And what happens in panic disorder is you start to worry so much about having another panic attack that sometimes that can almost like cause you to have more panic attacks. And then specific phobia is the fear of a specific object or activity. So we tend to think of these as things like arachnophobia, fear of spiders, or fear of snakes. But it can be things like fear of elevators or fear of public transportation that can really get in the way of you working. Now, post-traumatic distress disorder, PTSD, people traditionally think of a military veteran when they think of this. And certainly that can happen. And it's, unfortunately happens to a pretty high percentage of veterans. And certainly can happen to female veterans. I think of when I worked at the VA, there was a woman who had PTSD because she had been a dental assistant, and it was her job to identify people's bodies based on their dental records. So just think about how difficult that would be, right? But women can also get PTSD, and really anyone, but here we're talking specifically about women, because of things like a car accident, surviving a fire, sexual assault, sexual abuse, things along those lines. So now we're seeing, okay, as we've learned, that happens more often to women, right? And it happens more often to non-binary, trans people, members of the LGBTQ community, other minority status groups, women with disabilities, women of color. So now we're seeing how this can intersect. So PTSD occurs after directly experiencing or witnessing a shocking or frightening event. And there's a whole host of symptoms you can get. So re-experiencing where you have nightmares about it, or flashbacks where you actually feel like you're there in the moment. And it can be really hard to shake that. Avoiding anything associated with the trauma, which can be pretty difficult, right? So for example, I had a vet I treated who had gotten out of the service but still worked civil service, and he had to leave the room whenever they talked about Iraq and Afghanistan, but he was working at the Army base, so that was a lot. So it really interfered with his work, right? For some of the women I worked with, they avoided sex, right? And not only is that potentially a fulfilling part of their own experience, but also made interpersonal relationships difficult sometimes. Sometimes they feel just like a general sense of numbness. And then they have what's called physiological reactivity. So there's hypervigilance, where they're sort of always on their guard, always looking around to see if anything can happen. And then they have an exaggerated startle reflex, where if you do somehow sneak up on them, they're going to really be overreactive. So again, thinking about examples here, a friend of mine on internship treated someone who, when his kid woke him up, he grabbed his kid by the throat. The kid was okay. He didn't harm the kid in any way, but certainly scared both him and the kid, because in his mind, it was an enemy combatant. Complex PTSD are trauma responses to ongoing prolonged interpersonal violence during childhood and adolescence. And this can include things like an inability to foster stable relationships, stress-related physical ailments, and difficulty maintaining boundaries and personal safety. So a woman I treated who came to me because of a military sexual trauma, so she was sexually assaulted by a fellow soldier, also told me she was repeatedly abused by multiple male members of her family. And she had all of these hallmark symptoms. It was really just devastating. Historical trauma is unresolved grief that affects an individual or group in successive generations for those who have suffered significant trauma. So I talked a little bit about this. For Black America. Sometimes people call that post-traumatic slave syndrome, where the trauma of slavery and its legacy continues to manifest in successive generations of those who've suffered significant trauma. Native Americans can also experience continued distress for previous generations by being forced into residential schools. So children on reservations were taken from their parents, forced to cut their hair, forced to only learn and speak English. Abuse was rampant there. And then also for Native Americans, their land being taken away, right? Alternately, successive generations may inherit legacies of strength, spirituality, perseverance, vitality, dynamism, and resiliency. And that can contribute to what's called post-traumatic growth. And one thing I would like to note is that, you know, your book says alternately here, but you can have both. You can experience both. All right, eating disorders are my area of study. I literally teach an entire course about this. So I could go on and on and on. I'm going to try not to here. But this goes back to a lot of what we talked about when we talked about women's bodies. So the thin ideal contributes to gender and racial differences in eating disorders. Now, really interesting note about that is they're not as stark as we once thought. So if you look at the DSM, it argues that like 90% of people with the traditional eating disorders are female. Data's really not showing that's not true, that in fact, men may be a quarter to a third of people with disordered eating. And in fact, the racial differences we thought were there really aren't. So actually, I'm attending a virtual conference right now, the International Conference on Eating Disorders. And I was just on a workshop last night that talked about how we miss these eating disorders in particularly people of color, for example, because they might not be the stereotypical presentations. They might not be thin, right, but still have disordered eating and be really dangerous to themselves because of it, but because we have this narrow view of who gets an eating disorder, we could be missing. So it's really important within my subfield that we continue to analyze that. So anorexia nervosa is self-imposed food restriction, and really that's like an understatement. We're talking people will only eat 200 calories a day sometimes. And this results in significantly reduced body weight, or if it's in a kid, that they're not growing at the rate they're supposed to, fear of gaining weight, and disturbance in how their weight and shape is perceived. So they'll look in the mirror and see themselves much larger than they are. There's an activity I actually did with one of my clients with anorexia, where you can have them estimate their shoulders, waist, and hips. And we did this on a whiteboard, and then I turned her around and I actually marked where they were, and she was like pretty darn accurate on her shoulders, but overestimated by like a couple inches on each side of her waist and her hips. Like she thought she was that much bigger than she actually was. And even though she had felt me marking right next to her with the marker, she didn't believe it when she saw her actual marks. Bulimia nervosa is characterized by binge eating episodes where you eat a large amount of food in a short amount of time with a sense of loss of control. And then compensatory behaviors. And people tend to think only of vomiting here, but it can also be laxative use, diuretic or water pill use. It can be over-exercising, and it can also be fasting times as well. I had a client with bulimia who would try not to eat all day. And so then by the time it got to like 3 o'clock, she would end up binging, not only to deal with emotional things going on, but also because she just got hungry, and that's fairly common. Binge eating disorder involves recurrent episodes of binge eating in which a person feels distressed and disgusted over each episode. So it's bulimia without the purging. And this is one that we sometimes miss. Borderline personality disorder it involves a poor sense of self, including self-criticism, feelings of emptiness, impairments in interpersonal relationships, impaired empathy and intimacy. They'll have difficulties with like their own identity. And one thing that this doesn't mention that I think is really important is that people with borderline PD self-harm. And that's really one of the hallmark symptoms. And it's terrifying as a therapist. So they'll cut themselves, burn themselves. I had a client with borderline PD I saw on internship who had tried to kill herself by overdosing on her medications 3 times in the month before I started seeing her. So they can be very dangerous to themselves. We see this overdiagnosed in women and, to be honest, underdiagnosed in men. So about 75% of people diagnosed were women, but what they found as they get more accurate diagnosis and do research is that the rates are actually similar among men and women. This is also similar to depression. So we think part of what happens with the gender difference in depression and in BPD is that men are less likely to present. And also we may be more likely to diagnose the man with something else. So maybe the man comes in and he's been self-medicating with alcohol for this disorder or for depression. So we're gonna diagnose him with a substance use disorder rather than what might be underlying it. Borderline PD is strongly linked to experiences of childhood trauma, especially childhood sexual abuse. Okay, anyone who's had me in any class before knows that I absolutely hate this diagnosis. So woohoo, we're gonna talk about premenstrual dysphoric disorder, or PMDD. So this is diagnosed when women have symptoms of depression related to their menstrual cycle, basically. And it seems like there might be a very small percentage of women for which this is actually distressing. But generally, the symptoms are really problematic. So they pathologize natural reproductive processes, dismiss legitimate emotion women feel, right? Like, oh, are you PMSing when you have a legit emotion? And they benefit pharmaceutical companies. Little story here is that there was an antidepressant and its patent was about to run out. And so they literally dyed it pink and rebranded it for PMDD. So they got to keep their patent. Yeah, and again, think about what I said at the beginning about how disorders end up in the DSM when there's a medication, right? If you look at the symptoms for this, you could see how it could easily be misdiagnosed and pretty much any woman could experience it. So some of the symptoms include a sense of bloating, cravings for specific food during parts of your menstrual cycle, right? So like things that most women who are people who have periods have experienced. And so that's really difficulty, right? All right, so feminist therapy. And I do have to say here that I am not trained in feminist therapy at all. I was trained in cognitive behavioral therapy, which has a lot of empirical support behind it. But there are important feminist concepts that I think are incorporated not only into sort of the manualized aspects of those therapies, but also by therapists like the therapist I was, who are very sensitive to these issues. So they conceptualize mental illness as a disease within the individual, but also a response to relative powerlessness. So it's sort of like some of these disorders are rational responses to our society, right? So within eating disorders, for example, having an eating disorder might not be that irrational in a world that's so obsessed with the thin ideal, right? So they aim to help clients develop feminist consciousness, and the therapeutic relationship is seen as collaborative and egalitarian. Again, I think this carries over into other types of treatment. When I was doing CBT, I always told them, like, this is a hypothesis we're going to try together. And I would say things like, you're the expert on you, I'm the expert on the therapy, so we have to work together. And then the therapist does use self-disclosure when appropriate to encourage trust, empathy, and equality. And that's something that is sort of controversial within different types of therapy. Multicultural competence is really emphasized. So recognizing how intersectionality affects clients, not only their social identities, but their lives, their mental illness. So this requires dynamic sizing. So knowing when to generalize about a client's cultural heritage and when to consider that person's unique situation. And class competency, which is how to modify therapy when working with people with lower incomes. So things like, you know, you're gonna have to do this activity for an hour every day. Might not work if the person has to work 3 jobs, right? So thinking about things like that. I would say that the vast majority of, especially therapists who are being trained now, do these types of things. So for example, one of my first clients was Egyptian from Cairo and she was Muslim. And so I did some reading about her general culture, but I also did dynamic sizing, and I asked her about what her culture meant to her and what did wearing the hijab mean to her, and we worked within that framework as well. So in terms of techniques, you want to emphasize the personal as political. This is really a feminist concept beyond therapy as well. The idea that, things that affect us are things that we need to work on a larger scale. You encourage self-care. You try to cultivate assertiveness and autonomy. Again, this is something you do in other therapies as well. You might incorporate what we call assertiveness training, where you teach people how to interact in a way that they can advocate for themselves. And part of feminist therapy might be advocating for social justice. So one of the therapies they talk about in your book is dialectical behavioral therapy. I do have training in this. And this was developed for individuals diagnosed with borderline PD. And it has a group component where you do training in certain skills. So mindfulness, social skills, distress tolerance, emotional regulation. But then there's also an individual component where you work on the problematic behaviors like the self-harm. There's also two other components of DBT. One is being available for phone consultation or coaching. When the person feels like they are going to self-harm, they're supposed to call you as the therapist before they do it, and you try to give them skills they can do instead. And then the fourth component, which I think is really important, is a recognition that the therapist needs support. These clients are really difficult to work with because you're so concerned about their lives, to be perfectly honest. When I was doing DBT, I would wake up in the middle of the night sometimes worried about my clients. And so the therapist is supposed to have a support group of supervision of other people doing DBT. All right, so that's a nice little overview for y'all. Hopefully that's helpful, and I'll see you in the second half of the module.